Hello and welcome to this pharmacology class on anti-protozoal agents presented by Taylor, Humphrey and Sivesanzide. Okay, so let's start off by looking at what protozoa actually are. So they are defined to be unicellular eukaryotes that have cellular metabolism and processes that are actually more closely related to those of humans than those of bacteria. For this reason, they are far less easily treated than bacterial diseases. Anti-protozoal agents have since been developed and prevent disease either by destroying the parasites, inhibiting their reproduction abilities, or by reducing their growth abilities. It is important to note that protozoal infections are more common in undeveloped areas where the sanitary and hygiene conditions are not as pleasant. And then also these drugs can be questionable because the effectiveness is highly diminished by resistance development. So they very easily develop resistance against these drugs. Anti-protozoal agents are mostly administered orally and can be classified into two main groups, namely your anti-malarial drugs and your miscellaneous anti-protozoals. In addition to this, some can also be used for bacterial infections. Then, if we go into a little bit more detail with each classification, starting with anti-malarial drugs, these include the mefloquine, chloroquine, proguanil, atovaquone, and doxycycline, and they work by affecting different stages of the parasitic life cycle, which is later explained in this presentation. Anti-malarial drugs are mostly used as prophylaxis, but can also treat the actual disease, and the prophylaxis is highly dependent on the destinations that you're going to visit, and they also tend to look at your previous health status and your traveling behavior. Then when we look at miscellaneous antiprotozoals, these include your metronidazole, tinidazole, and nifurtide. Metronidazole is your most common treatment for trichomoniasis and giardiasis. Tinidazole works similarly to this, and it has some of the same side effects, but it's only given as a single dose and no follow-up doses are administered. And if these don't work, nifurtide can be used as an alternative. At this stage, the only existing theory on the mechanism of metronidazole is that it damages the protozoal DNA. If we then look at malaria a bit closer, it is a parasitic disease that is very common and causes illnesses all around the world. It has 5 subtypes, which you should have heard before, that are all responsible for causing disease, of which the first is your most common, your Plasmodium falciparum. Then you have Plasmodium vivax, Plasmodium malaria, Plasmodium ovale, and Plasmodium knowlesi. The drug resistance that I did mention earlier is most commonly problematic when Plasmodium falciparum is involved. So let's look at the parasitic life cycle. It obviously starts with the Anopheline mosquito that bites you, which then inserts its plasmodium into the human circulation. The plasmodium consists of sporozoids, which once in circulation rapidly moves to the liver, where it will then enter the tissue cells and mature into merozoids. These merozoids then move out of the liver and then tend to invade adjacent erythrocytes. This is where they cause infection. This cycle repeats itself over and over, and then the merozoids continue to form gametocytes. These form into or develop into sporozoids again and enhance the infection rate. So it's basically just like a ripple effect. Treatment has to focus on then eliminating the parasites in the erythrocytes to prevent spreading. These are just some pictures of the Anopheline mosquito, the vectors for malaria. And then here's just something that you can go read through. It's other protozoa of medical importance. Obviously, other forms of protozoa are also responsible for disease. So what are antiprotozoals actually indicated for? Here is just a simple list. It's malaria, amoebiasis, leishmaniasis, trichomoniasis, giardiasis, and trypanosomiasis. It is, however, important to note that these are all parasitic causes of infection. It is not an infection itself. It can cause more than one infection, but by knowing how the infection developed, you can know which medications to use. Then if we look at contraindications, for most anti-protozoal agents, pregnancy and breastfeeding women are actually contraindicated purely for the reason of previous adverse effects experienced. Then if we specifically go into proguanil with atovaquone, these should ideally be avoided in patients with kidney problems. This is because most of its metabolites are excreted by primarily the kidneys. Then if we look at doxycycline, it should also be avoided in children, mostly those under the age of 12. There's many reasons for this, but it can mainly stain the teeth of children, which is not ideal. Then if you go to nifurtol, nifurtol should not be used in patients with renal impairment, neuropathies, or G6PD deficiency, which is an enzyme that mainly just helps with your red blood cell functioning. It also, the reason for this is because the mechanism behind it is it damages your red blood cells, and if you have a deficiency, it will damage the only existing ones that you do have. And lastly, we can look at chloroquine contraindications. These include liver disease, GI diseases, neuropathies, cirrhosis, and prolonged QT interval pathologies, simply because it can worsen all of these pathologies. Okay, now if we look at drug-drug interactions that are involved, specifically in the use of antimalarials, we will look at quinine and quinine derivatives. These tend to increase the risk for cardiac toxicity and convulsions, and when used together with antifolate drugs, they increase bone marrow suppression. Signs of this are diarrhea, fatigue, weight loss, and anemia. So when left with no choice but to use them together, it is important to look out for these signs. Then drug interactions involved with other antiprotozoals. These include alcohol, oral anticoagulants, disulfiram, and quinine. Alcohol causes severe adverse effects, mostly with tinidazole and metronidazole, and for this reason should be avoided at least 3 days after being treated. Oral anticoagulants cause increased bleeding with metronidazole and tinidazole. Disulfiram, this is used to treat alcoholism, and therefore if they don't interact well together, they increase psychotic reactions with metronidazole and tinidazole. And then lastly, quinine potentiates neuromuscular blockers and also elevates your digoxin levels. So they don't go well together. Alright, so the adverse effects of anti-protozoal agents. Side effects are highly dependent on the drug and can vary according to the mechanism of action involved in each drug. So these here on the left, you can see it's just general adverse effects, and then we will go into the adverse effects of each specific drug. Starting with generally, so most of the time they can all cause nausea, vomiting, it can cause an upset gastrointestine, and also stomach aches. If we look specifically at metronidazole, it has been said that patients get this funny metallic taste in their mouths, and it kind of stays for a while. Then they also can get a yeast infection in the mouth, and then sometimes, but also not very common, a neurotoxicity. This includes dizziness, vertigo, numbness, and paresthesia. Then moving on to primaquine. This first point I did mention earlier as a general mechanism of action, but it can cause drug-induced hemolytic anemia, mostly in your patients with a G6PD deficiency. Okay, then it can cause abdominal discomfort and methemoglobinemia. Going to chloroquine, can also cause an upset GI tract, pruritus, headaches, blurred vision, and then with your chronic use, it can cause discoloration of your nail beds and some mucous membranes. Then you get some drugs that have a little bit more dangerous side effects. Here's a list of them. Due to the nature of these drugs aren't as common, but you are more than welcome to look or to read through this list. Okay, looking at the target organs and the target systems, most of these will be mentioned in the mechanisms of actions, but these are just some ways that these medications can work. So they mostly target specific stages in the parasitic life cycle, this to prevent the development and spreading of the parasite. In the blood stage, some prevent the detoxification of the heme molecules. Others inhibit the DNA synthesis of the parasite, and then you get others that involve the translocation into the cell and interaction with intracellular targets to cause the collapse of the metabolic and bioenergetic pathways. Some then work via the histatin 5, which is a cell-penetrating peptide targeting mitochondrial ATP synthesis. This causes cell death. Other drugs work by exoerythrocytic forms of Plasmodium to prevent reinfection, and then you get drugs that prevent DNA synthesis in a parasite's life cycle. Okay, starting with primaquine, it works by using its metabolites. So these act as oxidants that hemolyze the red blood cells to get rid of the infectious disease. And this is also what causes the methemoglobin in toxicities. Then if we move on to metronidazole, it has a nitro group that serves as an electron acceptor. This reduces cytotoxic compounds that bind to the proteins in DNA, which causes death of these parasites. This is important in amoebas specifically because they possess electron transport proteins. These proteins are involved in the metabolic electron removal reactions responsible for illness. So, going on to chloroquine. Chloroquine works on a specific site in the parasitic life cycle. So I'll just quickly explain how it gets there. So the parasite digests the host cell, the hemoglobin of the host cell, in order to obtain its essential amino acids. This process releases large amounts of heme, which is actually quite toxic to the parasite, but the parasite has a protective mechanism where it ordinarily polymerizes the heme to non-toxic hemozoin. This is in the food vacuole of the parasite. Now when chloroquine comes, it prevents this polymerization to hemozoin, and the accumulation of heme then results in cell death of the parasite and of the red blood cell. Okay, so atovaquone works by inhibiting the cytochrome BC1 complex in the mitochondrial electron transport chain. This chain has been mentioned quite a lot within the last few slides, just showing its importance in the mechanisms of most drugs' actions. And then it also has ATP and pyrimidine biosynthesis as part of its mechanism of action. Moving on to the pharmacokinetics. Again, each drug will be different. So metronidazole, it has good oral absorption, it is well distributed, and the metabolism is mostly hepatic. Primaquine is also well absorbed orally. It, however, is not very well distributed. It is minimally excreted in the urine and rapidly oxidized. Chloroquine is rapidly absorbed orally. It has a large volume of distribution, and it does indeed cross the blood-brain barrier, meaning it does have central nervous system effects. It is dealkylated by the liver, and then it is excreted by the urine mostly. Okay, then pentamidine is given either IM or IV. It can be given as via nebulizer, but it's not very common. It is widely distributed and is predominantly concentrated in the liver. It doesn't cross the blood-brain barrier and doesn't really have CNS involvement. It is not well metabolized and excreted very slowly by the urine. Here is just a list of the duration of action of each, if you were interested in looking at those. Anti-Protozoal toxicity and hypersensitivity. So anti-protozoal agents usually have no allergy profiles, but at high doses they can, however, be toxic. So these are just important things to look for when your patient is on one of these medications. Chloroquine mostly causes neuropathies. It can cause myocardial depression, auditory impairments, and also it can also cause psychosis. Quinine has a lot of gastrointestinal effects, vertigo, blurred vision, and tinnitus. Primaquine is well tolerated but can also cause gastrointestinal effects, pruritus, headaches, and more serious toxicity involves hemolysis in the G6PD deficient patients. Anti-Protozoal agents generally have no dependence potential, but they do, however, have a high drug resistance potential, as mentioned earlier. This can be overcome by using a number of them in combination to prevent these occurrences. Intensification of antimalarial drug resistance can also be as a result from the cross-resistance between drugs of the same chemical family or that share similar modes of action. Plasmodium falciparum and Plasmodium vivax are responsible for the largest numbers of severe cases involving drug-resistant infections. Here's a list of existing agents and their trade names. Most are not on our scope of practice, however. Thank you. If you have any questions, you are more than welcome to ask either myself, Humphrey, or Seve Sanzile, and good luck with the worksheet.